In this video we will talk about atrioventricular nodal reentrant tachycardia. In atrioventricular nodal reentrant tachycardia, the reentrant circuit is located near to or within the atrioventricular node. The reentry circuit consists of slow and fast pathways which electrophysiological properties are similar to the tissue of the atrioventricular node. The mechanism of the impulse circuit is the same as in other reentrant tachycardias. Atrioventricular nodal reentrant tachycardia is more common in females. It usually manifests with rapid regular palpitations at a rate of 140 to 280 beats per minute. There is an abrupt onset and termination of the episode. There are several forms of atrioventricular nodal reentrant tachycardia. Typical or slow-fast atrioventricular nodal reentrant tachycardia is characterized by anterograde conduction via the slow pathway and retrograde conduction via the fast pathway. The retrograde P wave may be completely obscured in the QRS complex or may be seen at the terminal portion of the QRS complex as a pseudo or wave in lead V1 or pseudo-S wave in the inferior leads. At this ECG there is no pseudo or wave in lead V1 or pseudo-S wave in the inferior leads. This ECG shows pseudo or wave in lead V1 or pseudo-S wave in the inferior leads compared to sinus complexes. Supraventricular tachycardias are distinguished according to the RP interval, that is, interval between the R wave to the next P wave. If RP interval is shorter than PR interval, supraventricular tachycardia is called short RP tachycardia. In typical atrioventricular nodal reentrant tachycardia, the RP interval is less than 70 milliseconds. Atypical variants of atrioventricular nodal reentrant tachycardia include fast-slow and slow-slow. In the fast-slow type, the depolarization wave spread anterogradely via the fast pathway and retrogradely via the slow pathway. Thus, the P wave is seen on the ST segment or the T wave. However, this pattern is far much more common for atrioventricular reentrant tachycardia. If both pathways have slow conduction, the slow-slow type is said to be. This type is very difficult to distinguish because the retrograde P wave precedes the QRS complex. The diagnosis is confirmed with an electrophysiological study, as well as type differentiation. Atrioventricular nodal reentrant tachycardia may be terminated by vagal maneuver, intravenous adenosine, beta blocker, or verapamil. In hemodynamic compromise, cardioversion is performed. Beta blockers or calcium channel blockers are used for prevention of atrioventricular nodal reentrant tachycardia episode. Catheter ablation is very effective. Thank you for watching this video. Please like and subscribe.